Hello doctors, this is Dr. Hira Salman. Today we are going to complete this sports medicine. We have to finish this chapter today. So starting with this decurving tenosynovitis, see this is also known as mommy thumb. This presents as pain and tenderness over radial side of the wrist. Which side of the wrist? Radial side of the wrist, thumb side of the wrist. Decurving tenosynovitis is an overuse injury caused by repeated thumb abduction and extension. So this is all just because of overuse injury. This injury is actually caused by overuse, that is by repeating thumb abduction and extension movement all the time. The pain results from inflammation of the tendons of the extensor pollicis brevis and abductor pollicis longus. So actually these two muscles, their tendons when get inflamed, they can result in decurrent tenosynovitis, right? So one is pollicis, both the pollicis, like thumb, pollicis means thumb, right? So extensor pollicis brevis and abductor pollicis longus, both are the thumb muscles. When their tendons inflamed, they lead to decurrent tenosynovitis, which are the first compartment of the wrist in the anatomic snuff box. Look for a new mother constantly holding her baby. Bowling and texting are other common causes. So see, texting the messages, so that can also lead to decurrent tenosynovitis because there is continuous movement of these muscles, which can result in inflammation and can cause this injury because of the overuse and result in tenosynovitis. So how are you going to diagnose your test? First of all, you will do this Finkelstein test. What is this Finkelstein test? Have patient flex the thumb into the palm. You will ask your patient, like in diagram, and I'll show you the video also, that you're going to ask a patient for the flexion of the thumb, like to flex the thumb into the palm, making a fist, and then ulnarly deviate the wrist. You ask a patient to deviate it on the side. If the test is positive, if it reproduces pain, so if there is pain by rotating or by deviating it to the ulnar side, this wrist, if there is pain, then this is a positive test. Now for the treatment option, treatment is conservative. You will go for thumb spica splint casting. You will go for NSAIDs, the best lethal one, and corticosteroid injection if the patient's symptoms not improved by taking NSAIDs and by applying this thumb spica splint. So this is the one. Now T-current tenosynovitis, you have to remember that it's overuse of abductor pollicis longus and extensor pollicis brevis. These are in handy points. You will go for this Finkelstein test for this, and thumb is stuck inside finger fist and wrist is ulnarly deviated. If the pain is there, it means that this is a positive test. So I think I should go for the Finkelstein video first, and then we'll continue.
Impingement syndrome. Near to.
We have already gone through it. We have to see this.
Finkelstein's test can be utilized to identify tenosynovitis at the thumb. The patient is instructed to make a fist, placing the thumb inside of the fist. The clinician will next stabilize at the patient's wrist while grabbing the hand and producing an ulnar deviation. A positive test is reproduction of concordant pain over the abductor pollicis longus or extensor pollicis brevis tendon. Currently, the clinical utility of this test is modest due to the modest sensitivity and specificity found through diagnostic accuracy studies.
All right. Okay, now we're coming towards scaphoid fracture. See, scaphoid fracture is also known as fall on outstretched hand, that is FOOSH. FOOSH means that FOOSH is an acronym and it stands for fall on outstretched hand because it is caused by a fall or trauma on an outstretched and dorsiflexed wrist. So if the wrist is dorsiflexed or if the wrist is outstretched and if there is fall in that position, of this trauma in that position, that can result to scaphoid fracture. The scaphoid is the most commonly fractured carpal bone in about more of 70% cases. Usually in case of this fractured carpal bone, the one which is the most commonly fractured is considered to be the scaphoid bone. This injury involves the risk of avascular necrosis of the scaphoid due to unusual blood supply that flows distal to proximal from the radial artery. So we have to memorize this point as well, that this injury involves the risk of avascular necrosis. So this is the one which is commonly fractured about more than 70% of cases. That's the scaphoid one, this point. And second point which we have to remember, that this is scaphoid fracture, there is involvement of the risk of avascular necrosis. Definitely avascular necrosis of this is scaphoid bone, right? Now look for pain with palpation over the anatomic snuff box. When you just palpate over the anatomical snuff box, there you can see anatomical snuff box. In the base of this box there is radial artery, right? And this snuff box is not an anatomical one, actually it's just formed by the tendons of especially this index finger and the thumb. So you have to look for pain with palpation of the anatomic snuff box. If pain is there, it means that there are chances of a scaphoid fracture. So how we are going to diagnose and what are the diagnostic tests that we have to perform and what option we are going to go for the treatment. So best initial test is plain x-rays. If fracture is not seen on imaging but it's suspected, you have to treat as fracture. See, if fracture is not visible but the patient is having pain, right? So you have to treat it accordingly. Fracture is not seen on imaging but it is suspected, so you can go for the treatment on the basis of suspicion, on the basis of a suspected thing also. You are going to immobilize your patient, especially the wrist, in thumb spica cast for 10 to 14 days and then repeat x-ray to confirm fracture. You're just going to apply the splint over the thumb, right spica cast splint for 10 to 15 days, and you have to repeat x-ray in order to confirm fracture. That later on you can also go for. Now, MRI or CT can make immediate diagnosis, but it's not the best initial test. Of course, if on first thing by doing plain x-ray, if you didn't get anything, you can just repeat the x-ray after 10 to 14 days, right? But it's not like that you will directly go for the MRI because you haven't seen anything on x-ray. No, we can't do that because MRI or CT, they are not the immediate diagnostic testing and not the best initial test. CT is the best test, means it's the most accurate test for the patient that are still symptomatic after 4 to 6 weeks of treatment. You have already applied treatment for 4 to 6 weeks, still your patient is not responding and he is having the same pain and same condition, then only we can go for CT scanning, right? Non-displaced fracture, thumb spica cast you are going to apply for more than 6 weeks if there is a non-displaced fracture. And if there is a displaced fracture, like if it's more than 2 millimeter in size, then you will go for open reduction and internal fixation. This ORF stands for open reduction and internal fixation. Remember, when you're going to do this open reduction internal fixation in case of displayed fracture. Now we're coming towards lower extremity, that is the hip, knee and foot. First of all, we are going to cover this avascular necrosis of the femoral head. This is an insidious onset of hip and groin pain that is worsened by activity. Say for example, stairs, incline, weight bearing, but relieved by rest. So the pain is excruciating. There will be insidious onset of the pain when the patient is climbing or even during inclined position, especially in the hip area or in the groin area, and weight bearing but relieved by rest. So this is the most important point, that it's going to be relieved by resting. Avascular necrosis of the femoral head result when the vascular supply to the femoral head is disrupted. Of course, when the vascular supply is compromised, at that point you will see avascular necrosis. Look for a younger patient, like less than 40 years of age, right, with the following risk factor. If your patient is young and he is having any one of the following risk factor, you have to look for that patient, like he is having a history of his steroid use, he is a case of sickle cell disease, he is alcoholic abuser, right, he is having osteomyelitis, he is having systemic lupus erythematosus, or any previous fracture history or dislocation or surgical fixation history. So these are all the risk factors, especially in young patients, right? Age and risk factors are main clues to differentiate avascular necrosis from osteoarthritis of the hip. So that is very important, because that osteoarthritis of the hip, their avascular necrosis is purely an aging phenomenon. And here in young patient, if it's there, so it's mostly because of mostly because of weight bearing areas and worsened by activities, and mostly in young patients you're going to see this. Now for the diagnostic testing, we'll go for the MRI. MRI is considered to be the most sensitive test. Here you will not go for the CT, you will go for the MRI. This we need to make a note of it. X-rays are normal in first few months of pathology and normal ESR, CRP and WBC. So you are not going to get any extra pathology or any sign and symptoms of pathologies. Just normal ESR, just CRP, WBC, but X-rays are also normal in first few months of pathology, and MRI is the one which is considered to be the most sensitive here. How we are going to treat our patient? Avascular necrosis of the femoral head needs total hip arthroplasty replacement. Definitely we have to go for total hip arthroplasty replacement. That is for avascular necrosis of the femoral head. You have to replace it via surgical procedure, that is total hip arthroplasty. Now we're coming towards osteoarthritis of the hip. Look for a progressive hip and groin pain that is worse with movement in patients, like those who are more than 50 years of age. So in old patients especially, if the pain is progressive because of the movement, we always think of this osteoarthritis. Pain at rest usually correlate to clinically significant X-ray findings. Osteoarthritis of the hip is caused by overuse, there may be trauma, there may be chronic degeneration of articular cartilage. It can be of any reason. Maybe because of the chronic degeneration of articular cartilage, maybe because of trauma, maybe because of overuse, that we can see if there is a case of osteoarthritis. And how we are going to diagnose these patients? First of all, we will do the X-ray, then we'll go for the physical examination demonstration itself, which showing the limited range of motion and positive Faber or Petrick test. We'll see this Faber test and Petrick test, but just to have a look, have an idea here, you have to memorize that osteoarthritis. In osteoarthritis patient on physical examination, you will found limited range of motion and positive this Petrick test. Now for the treatment option, we have to go for the conservative until pain is intolerable, then total hip arthroplasty replacement. So of course we'll go for the arthroplasty replacement if the patient is having, first we need to manage conservatively, right, until the pain is intolerable. When the pain is intolerable, then definitely you have to go for total hip arthroplasty replacement. So he's showing the Faber, that is Petrick test. So I think we should go for the video first.
Close. Next test, guys, Faber test, F-A-B-E-R. Reason it's called Faber test is because of the hip position. When you start the test, it's the hip is inflection, abduction, and next rotation. That's Faber. It's also called Patrick's test and Figure 4 test. With this test, I'd be on the other side, but just for visualization, we'll stand here. You have the patient go in a Figure 4 position. It's a passive test. If the patient's with their lateral labus just superior to their patella, stabilize here. And if the patient has a positive test, they're going to have more flexion with this. Occasionally, I'm going to apply just slight stretch on them like that. Positive test could be indicative of tightness of the iliopsoas of the joint hip flexors. Depending on, especially if I give some overpressure, if the patient has discomfort, you ask them where they have discomfort. It could be hip flexor pathology, it could be SI pathology. So again, if I push back and she's complaining of some discomfort in the middle body region or the SI region, typically unilateral, positive test for that, and it can also be some hip pathology with this too. So again, depending on the sensation she has with that. So if I give overpressure, push down, and she complains of deep hip discomfort, it could be some hip pathology we're dealing with that, whether it's a labor or arthritis. Typically, the Faber test does look for the SI pathology with that. So again, positive test will be up higher. The negative testing comes pretty much parallel to the table. She's almost there. I'd say she has slight tightness with that. But towards this being a negative test with that. So that's a Faber test, a Patrick test, Figure 4 test.
All right, Now we are coming towards knee injuries. Knee injuries, first of all, we have this anterior cruciate ligament tear. This is the most common ligament tear injury of the knee. So the most common ligament actually injury of the knee is this anterior cruciate ligament. So it is a non-contact but dramatic injury caused by dramatic cutting or deceleration and hyperextension of the knee. Maybe those are case with footballers or soccer players or skiing patients. In all of these conditions, there must be a dramatic. It may be because of the dramatic cutting, or it may be because of this deceleration or hyperextension of the knee because of all this. Right, during football match or during soccer, the soccer player can do this. Yeah, this injury can happen in that patient, or skiing patient during skiing. That can also occur because of the hyperextension of the knee. So they are the causes actually that we have to memorize, that this is the most common ligament injury. It can also be caused by valgus stress on a flexed, planted and rotated knee. We'll see this valgus stress test. So it can also be caused by valgus stress test on a flexed, planted and rotated knee. More than 50% of patients with anterior cruciate ligament tear have a concurrent meniscal injury. Look for an injury described by starting with an audible pop with anterior knee pain, instability and effusion. Most of the time, if it's a case of anterior cruciate ligament, you will see this audible popping. You will actually hear this audible popping with anterior knee pain. There is instability of the joint and effusion is also there. Then you should always make a diagnosis of this anterior cruciate ligament tear, right? Now, for the diagnostic point of view, we'll go for the physical examination first that demonstrate the decreased knee flexion secondary to effusion or hemarthrosis. Joint line tenderness is common due to secondary pathology. That is all meniscus we can see. Just joint line tenderness is common due to secondary pathology, and that's meniscus. So on physical examination, you can diagnose with the help of this decreased knee flexion, which is secondary to either effusion or hemarthrosis. Then we have this anterior drawer sign with patient supine and knee flexed to 90 degrees. With patient supine, the position of the patient will be supine, and you're going to ask for the knee flexion to 90 degrees. If they pull anteriorly on the tibia, if it slides easily in relation to femur, it is a positive test. That's known as anterior drawer. I'll show you the video of anterior drawer and this, especially this valgus stress test. But till then, you just have an idea that in case of anterior drawer, what is actually happening. We ask a patient for the supine position and we'll flex the knee up to 90 degrees, and we'll pull and if there is pull anteriorly on the tibia, if it slides easily in relation to femur, it is a positive test. Then Lachman test. I'll show you the video of Lachman test also. With patient supine and knee flexed to 30 degrees, pull anteriorly on the tibia. If it slides easily in relationship to the femur, it is a positive test. So again, in case of Lachman, you ask your patient for the supine position, you flex the knee, but not this time, not 90 degrees. This time for the Lachman test, you will ask only for the 30 degrees. And if there is pull anteriorly on the tibia, and you have to pull anteriorly on the tibia, if it slides easily in relation to the femur, if sliding is there, easy sliding, then this is known as positive test. The Lachman test is more sensitive than the anterior drawer test. So same thing, both of them are going to measure anterior drawer also and Lachman also. Now the best initial testing is MRI. MRI is considered to be the gold standard, like 80 to 95% sensitivity is there with the help of this MRI. And the most accurate test is arthroscopy. Arthroscopy is having 100% sensitivity. So 100% sensitivity because of this arthroscopy is all in the case of especially this tear that is known as anterior cruciate ligament tear. So how we are going to treat this patient? Most require arthroscopic surgical reconstruction with the graft. So we will go for the grafting procedure with the help of arthroscopic surgical reconstruction. So before going towards common knee pathologies, we have to see 3 test videos. First is valgus stress test, second is anterior drawer sign, and we'll see the posterior drawer also, and this Lachman test.
Finkelstein.
This next test of the knee will produce a special test. This is the Barris test. Barris stress this test on the position again on the outside. From here, I'm going to palpate, come up into the medial side of the condyle, find the joint line. When I find that joint line on this medial side, that ropey feeling that I have right here is my medial collateral ligament. From this position, my mobilization hand is going to put a valgus force onto this medial collateral ligament. We'll take from extension to flexion, in range of extension, slight flexion, a few degrees, and I'm going to do a valgus stress, okay? Medial collateral, valgus stress, lateral collateral, varus stress.
Lachman test. The Lachman test evaluates the stability of the anterior cruciate ligament, or ACL. With one hand, grasp the distal thigh and grab the proximal lower leg with the other. The thumb should rest in the area of the tibial tuberosity and the leg is flexed at around 20 degrees. To test the stability of the ACL, quickly pull the lower leg forward. If the patient's thigh proves to be too heavy, you can place your own thigh underneath the patient's for support. The translational forward movement tenses the ACL. Physiologically, you should feel a firm endpoint, just like you would when pulling on one end of a cord. A soft or absent endpoint, especially in comparison to the other side, indicates insufficiency of the ACL, and the Lachman test is considered positive. Additional tests to assess ACL stability include the pivot shift test and the drawer test, which are explained in separate videos. Drawer test. The drawer test is used to assess the stability of the anterior cruciate ligament, or ACL, as well as the posterior cruciate ligament, or PCL. Place the patient's foot on the bed so the knee is bent at 90 degrees. To prevent the foot from slipping, the examiner can carefully sit on the patient's forefoot. Grasp the lower leg with both hands, with the thumbs resting on the tibial tuberosity. To test the stability of the ACL, pull the tibia forward. For the PCL, push the tibia backwards. Physiologically, tibial translation movement should be minimal in either direction. The test is considered positive if there is excessive tibial translation, particularly in comparison to the contralateral limb. Excessive anterior tibial translation indicates a lesion of the ACL, whereas posterior translation suggests a lesion of the PCL. Always start the examination with the lower leg in a neutral position to avoid false positive test results. For example, if the PCL is insufficient, the lower leg might be displaced posteriorly at the beginning of the test. Performing the anterior drawer test from this position would then result in significant anterior movement even though the ACL could be intact, and the examiner may wrongly conclude the test is positive. The gravity test is another examination to assess the stability of the PCL. The ACL can be examined by performing either the pivot shift or the Lachman test. All of these tests are demonstrated in separate videos.
Alright, Now coming back towards our topic, and we are now going to this common knee pathologies. We have some pathologies, we are going to discuss their presentation, their special testing, how we're going to diagnose them, and what possible management options we are going to propose for them. So starting with this ligamental tear, it may be anterior cruciate ligament, it may be posterior cruciate, or medial collateral, or lateral collateral ligament. Any ligament tear is there, then we'll see step by step how they are going to present, and for them how what are the special tests, and especially how we are going to diagnose them, and what management we are going to provide them. So first of all, with this anterior cruciate ligament tear, this is a non-contact injury, most common cutting injury, right? It is a non-contact injury, and most commonly it is all because of cutting injuries. And posterior cruciate ligament is because of hyperflexion, posterior force, and a planted lag. In rare cases of car accident, dashboard injuries, you can see this posterior cruciate ligament tear. But remember, in case of posterior cruciate ligament tear, there is hyperflexion plus posterior phase on a planted leg. Now for the medial collateral ligament, we have this valgus force from a blow on a planted leg. And you have seen the video valgus and stress test, valgus stress test. So this valgus force from a blow on a planted leg, that is in case of football and soccer, that is resulting with medial collateral ligament tear. Or in the case of lateral collateral ligament tear, it's rare actually, but devastating injury associated with multiple pathologies and neurovascular injuries. So there are multiple pathologies, there are multiple neurovascular injuries in the case of lateral collateral ligament. So how we are going to diagnose these patients? The special testing for these procedures is NT and posterior dorsal. You have already watched the video of it, Lachman test and the valgus and varus stress test. We are already done with the video section of all these three tests. Now for the diagnostic point of view, diagnosis is purely based on MRI. Right? So it's a final diagnosis. It should be a most accurate one. And for the management part, we will go for the conservative, especially for the medial collateral ligament, we'll go for this conservative therapy, or we'll go for the arthroscopic reconstructive surgery. Especially for medial collateral ligament, we'll go for the conservative management. But rest of the pathologies will go for the arthroscopic reconstructive surgery also. Now we're coming towards meniscal tear. Meniscal tear is like joint line, that is joint line, knee pain if it's there, and clicking, popping, or locking with movement result from cutting this maneuvers, maneuvers that cause tibial rotation on a flex knee, that is in the case of footballer and soccer player. So here we have to memorize that meniscal tear is just, the etiology behind this joint line knee pain. It's a knee pain, joint line knee pain is there, and clicking, popping, locking is there, and it results from cutting maneuvers that cause tibial rotation on a fixed knee. That is also there in the case of football and soccer player. How we are going to diagnose them? With the help of this McMurray testing, or this Thesale testing, or Apply-Grind. We'll see the video of Apply-Grind, right? And how we are going to diagnose these patients? With the help of MRI, and we'll give the conservative therapy and arthroscopic reconstructive surgeries procedure for these, especially these things. Then we have this iliotibial band syndrome, right? Iliotibial band syndrome is a lateral knee pain over this Gerdy tubercle where the iliotibial band inserts, right? So it's there actually on the position where iliotibial band inserts. So it's a lateral knee pain, which not the medial one. It's a lateral knee pain over Gerdy tubercle. So on the lateral side actually. So that's why you are seeing this pain on the left side, especially where there's iliotibial band insertion. And this Ober test we are going to perform for this, and clinically we are going to diagnose it. And for the management option, we have this conservative. We can provide physical therapy to these patients. Then we have this patellofemoral syndrome, which is very important for exam point of view. This patellofemoral syndrome, that is a runner's knee. In case this etiology is anterior knee pain under patella, caused by overuse, muscular imbalance of quadriceps, and poor biomechanics like bowlect, or prolonged sitting and excessive activity, or exacerbating factors. There may be prolonged sitting, there may be excessive activity, there may be exacerbating factors which are there, but what is actually behind all this thing? There is anterior knee pain under patella, right? And why this anterior knee pain under patella? Because of the overuse of muscular imbalance. There is muscular imbalance of quadriceps. Quadriceps means four muscles: vasta medialis, lateralis, intermedialis, and quadratus femoris, right? These four muscles are known as these quadriceps muscles. And poor biomechanics, that's Bowlegs, prolonged sitting and excessive activity are exacerbating factors. So if we don't want to know the exacerbating factor, then these are actually excessive and prolonged sitting activities. How we are going to diagnose these patients on the basis of patellar grind test? Clinically, we are going to diagnose, and we will do conservative management and physical therapy. Then we have this patellar tendinitis, that is also known as jumper's knee. So in case of patellar tendinitis, there is inferior patellar knee pain. You are going to see episodic pain commonly occurs in athletes in jumping sports, say for example those who are a part of basketball playing and volleyball, and overuse injury caused by repetitive overload of quadriceps on patellar tendon. There you can see there is overuse injury caused by repetitive overload of quadriceps on patellar tendon. If there is repeated exposure of especially this overload of quadriceps on patellar tendon, that can lead to this patellar tendinitis or jumper's knee. How you're going to diagnose your patient? Pain with palpation over inferior pole of patella. If you palpate the inferior pole of patella and there is pain with palpation, that is known as patella. That may be a case of patella tendinitis. Clinically, we have to diagnose it, and for the further management, we'll go for the starting with the conservative management. We'll go for the physical therapy. Then we have osteoarthritis of the knee, which is very most important common thing in exam point of view. For exam point of view, especially like here we have medial lateral joint line pain. See, medial, which is more than as compared to lateral joint pain. It's not like that only medial pain is there, lateral pain is there. Both pains are there, but if we consider the one that is more, that is medial one. So medial is more as compared to lateral joint pain, and age should be more than 50 years of age. It should be obese and limited range of movement, having little limited range of movement. There may be crepitus with range of movement, small effusion, whereas angulation pain will be there, and weight bearing or activity. So if the pain is there because of any of the reason, we can say this is all because of osteoarthritis. And how we are going to diagnose these patients? On the basis of limited especially if we are considering active range of motion and passive range of motion. If both are limited, this will help in making a diagnosis of osteoarthritis. We'll go for the axillary testing as the best initial test, and we'll go for the conservative therapy and arthroscopic replacement, especially as a treatment option. Then this is anterior and posterior drawer sign. We are already done with this signs. Anterior posterior drawer test, hip flex 45 degrees, knee flex to 90 degrees. So knee should be 90 degrees, hip should be 45 degrees, and then you will do the anterior pull on tibia. So if there is ligament laxity, what you will see that ACL pathology or tear, of course, if there is laxities, that means that there is something goes wrong in anterior cruciate ligament tear, right? Or there may be a tear of ligament of this anterior cruciate. Posterior push on tibia. Tibia will be posteriorly pushed, and ligamentum laxity will be this, especially this PCL pathology and tear. This is posterior cruciate ligament pathology and tear. So if it's a case of ligament laxity, so in ligament laxity we'll see the posterior cruciate ligament pathology or posterior cruciate ligament tear, right? Or here the most important thing is that in the case of anterior posterior drawer test, there is posterior push on the tibia, right? That we need to memorize. You just see the video and you will get a clue how you're going to perform these testing. Lachman test, you have already seen this test on video. It's a hip slightly flex, knee flex to 30 degrees, anterior pull on tibia. There is ligament laxity. If there is ligament laxity, that is all because of anterior cruciate ligament pathology or anterior cruciate ligament tear. So in the case of, especially in case of this anterior posterior drawer testing, or in a case of this involvement, knee involvement, if we have this pathology in the posterior cruciate ligament, the most chances of having this anterior posterior drawer test positive. Those who having this especially anterior pull on tibia ligament laxity is there, or hip slightly flex, knee flex to 30 degrees, there's anterior pull on tibia, that lead to, that is actually if the pain is there because of this injury, because of the tear, then we can say this is a positive Lachman test. We've already seen that. Now, O'Donoghue unhappy triad. This O'Donoghue unhappy triad is a triple injury to anterior cruciate ligament, medial cruciate ligament, and medial meniscus. So, if there's any one of the injury, muscle or tendon is involved, this is anterior cruciate ligament and ligament, or medial collateral ligament, or you can see. So this is medial collateral ligament, and this is anterior cruciate ligament, right? So anterior cruciate ligament, medial collateral ligament, and medial meniscus, if are involved, if the injuries are involved, we can say this is O'Donoghue unhappy triad, and this is the very step, the one which is performing. Now, valgus and varus stress test. If the hip flex to 30 degrees, that is knee extended to 180 degrees. That's because of all valgus and lateral forces, right? So hip flex to 30, knee extended to 180, and it should be a valgus lateral force. In case if you remind this valgus stress testing, ligament laxity will be medial collateral ligament pathology tear will be there, whereas in medial force if you are considering, then ligament laxity is actually because of lateral collateral ligament tear. So if it's because of lateral collateral ligament tear, it's just because of the varus and medial force, right? This varus and medial force we are going to see here, and lateral collateral ligament tear, which result in ligament laxity, right? Or in case of medial collateral ligament laxity or tear, we'll see this ligament laxity, right? But it's over the, especially towards the medial side, right? Yes. Then we have this, well, because we are done with this testing. Now we're coming towards, and we have already seen the video also, right? Now we're coming towards meniscal tear. Meniscal tear occurs in young patients who commonly experience a pop followed by pain. Medial meniscus tear result from cutting maneuvers that cause tibial rotation on a particularly flat and fixed knee. That is in case of footballer players and soccer players. Lateral meniscal tears are caused by squatting with full flexion of knee and rotation. That is in case of wrestling, in case of squatting. The joint may feel stiff with decreased range of motion, especially with flexion. It will pop, catch, and lock with ambulation, stair climbing. Joint line tenderness will be there, and significant effusion may occur in the first 24 hours. So you can see in the first 24 hours there is significant effusion in these patients if there is a case of meniscal tear. So what are the special findings in these patients? The joint may feel stiff with decreased range of motion, especially with flexion. And what you're going to hurt? It will be a pop, catch, and log with ambulation, stair climbing. So how you're going to diagnose this patient on the basis of physical examination and McMurray testing. Physical exam reveals decreased knee flexion, secondary to effusion, joint line tenderness will be there, and pain on locking with provocative maneuvers. So if you do the provocative maneuvers, if the pain is there, so you have to examine it on the basis of physical examination. Then we have this McMurray testing with the patient supine and the hip and knee flexed. Remember, we'll see the video also. When the patient supine and the hip and knee flexed, palpate the joint line of the knee bilaterally. Externally rotate the tibia and apply valgus force while extending the knee to examine the medial meniscus. Examine the medial meniscus. Internally rotate the tibia and apply varus force while extending the knee to examine the lateral meniscus. To examine the lateral meniscus, you have to apply varus force. To examine the medial meniscus, you have to apply internal force or a medial meniscus. Especially for the medial meniscus, we have to apply medial force. Now, popping, clicking, and pain indicate a positive test. If there is popping, if there is pain, because of all this, then we can say this is a positive McMurray test. In fact, the positive McMurray test is the most common described exam on standardized testing, right? So this is the quite standardized test. Now we're coming towards this Thessali test. Thessali test is patient stands on the affected limb and rotate the femur on the tibia. So that is known as Thessali testing. That's a simple one. Patient stands on the affected limb. Whatever the limb is affected, he will be standing on that limb and rotate the femur on the tibia. Then we are coming towards applique grind. We'll see the video of this applique grind with patient prone and knee flexed to 90 degrees. The physician places compression through heel while internally and externally rotating tibia to grind the meniscus. MRI will be the gold standard. We should go for MRI, the gold standard therapy. But in case of applique grind testing, I'll show you the video. It will be very simpler for you then. But remember, in case of applique grind, with patient prone and knee flexed to 90 degrees, pronation and flexion to 90 degrees, the physician places compression through the heel by internally externally rotating tibia to grind the meniscus. Now for the treatment option, we have to go for this. If there is a mild symptoms in patients who are more than 40 years of age, then we go for the conservative management, and the rest activity modification will just give the painkiller, that is NSAID. But young patient with like more than 3 to 4 weeks of symptoms, arthroscopic surgical repair should be the best option, right? So what are the handy points of this applique compression testing? First is patient prone, knee flexed to 90 degrees. Patient should be prone and then knee should be flexed to 90 degrees. There will be axial compression, down leg into knee. Down leg into knee, you will see this axial compression, and pain will be there. That is considered as a positive pain, indicates a meniscal tear. If it's a meniscal tear, it will be represented by a positive testing. Alright. Now we're coming towards foot injury, and then in last I'll show you the remaining videos. So common foot pathologies are, first of all, plantar fasciitis, or a stress fracture, or Jones fractures, or motor neuromas, this tarsal tunnel syndrome, this hallux valgus, that is known as Bignon. So we are going to see all these pathologies in case of foot pathologies. Now how they are going to present, like if it's a case of plantar fasciitis, we'll see that it's a heel pain focal to the rear foot. Pain is greater with first step in the morning and then improve. Prolonged daily activity often causes the return of the patient at night. So see, these patients are having pain by just by doing the first step in the morning, and then rest of the time it will improve. So early in the morning the patient is experiencing pain, but with the passage of time, if movement is there, then definitely this will be slowed down. Now for the diagnosis point of view, clinically you have to go for the point tenderness, distal to heel, right? X-rays are not useful in this case, especially if it's the case of fasciitis. Now for the treatment option, conservative with stretching of plantar fascia, is steroid injection can be useful to refractory case. If it's a refractory case, if it's a recurrent one, we can go for steroid injection. Now for the stress test, pain in midfoot, second metatarsal, most commonly you will see there in these patients due to repeated tension, most commonly caused by dramatic increase in activity, maybe because of military man or athletic activity, can occur with poor nutrition. Nutrition is also very bad here. These patients are actually deficient of vitamin D or calcium. So vitamin D, calcium, a female athlete triad. This is also a triad in which you can see the female patient who is athletic one, when she is deficient in vitamin D and calcium. This triad we are going to learn, and she's having low calorie, low bone density, and amenorrhea. So how we are going to diagnose these patients on the basis of clinical examination? There will be X-rays are normal for 3 to 6 weeks, or MRI, CT, bone scans are more sensitive easily on, but we will never go for the initial testing with this MRI and CT scan. Conservative treatment you are going to offer with rest in wide, hard sole footwear, or this cam boot if more aggressive for fifth metatarsal. If it's more aggressive for the fifth metatarsal, we can go for this cam booting. Cam boot is a specialized boot for the protection of this little finger. Now, Jones fracture. Jones fracture is a fifth metatarsal fracture at junction of metaphysis and diaphysis. So, it's in junction, it's a fracture in the junction, right? Especially common fracture with ankle sprain and cause when heel is off the ground, but forefoot is planted. Risk of delayed healing if untreated, right? So, if we just left untreated, there will be delayed risk of healing. So we have to diagnose it by X-ray. We will give this non-displacement 6 to 8 weeks in cast and non-weight bearing. So those are the position in which the organ is or the particular organ is not weight bearing, and there's a non-displaced thing, and we have 6 to 8 weeks in our hand to apply the cast. So we'll go for that particular procedure. Then we have this motor neuroma, that's numbness and burning pain between third and fourth digits caused by an interdigital neuroma, thought to be a result of mechanical injury but unclear etiology. We don't know the etiology, unfortunately. Happens to both athletes and non-athletes. They are not particularly restricted towards athletes, they are for the non-athletes also, these motor neuroma. And clinically we have to diagnose this. We will find this Mulder sign. What is this Mulder sign? It's a squeezing metatarsal joint causing pain and crepitus at third, fourth digit. We have to use MRI, ultrasound MRI to confirm the diagnosis, right? So what is the main diagnostic testing for this is clinical, on the basis of clinical examination and on the basis of Mulder sign. Mulder sign is again very important because it's going to, we will see this particular sign when we ask the patient for squeezing metatarsal joint, and which is of course exhibit pain and crepitus in third and fourth finger. That is very peculiar for motor neuroma. And how we are going to manage these patients? Conservatively, we have to manage. We will give metatarsal support pads or wide, hard-soled footwear. That's the first line. So conservative will be the first line, and then of course injection and surgery for refractory symptoms. So if the patient's symptoms continue, we'll go for the, especially for the refractory cases, we'll go for the injections and surgery, corticosteroid injections and surgery. Then we have this tarsal tunnel syndrome. Tarsal tunnel syndrome, similar presentation to carpal tunnel syndrome, except it occurs on medial side of the sole of the foot. So if it's on the medial side of the sole of the foot, we can say this is tarsal tunnel syndrome, right? Then we have pain, tingling and burning with activity or at rest. Etiology is entrapment, especially entrapment of tibial nerve. Actually, what is the main pathophysiology behind this nerve is trapped this nerve. Which nerve? This particularly where? This is, yeah, this tibial nerve. Entrapment of the tibial nerve under flexor retinaculum. So flexor retinaculum is actually going to trap this tibial nerve by tenosynovitis of the tibialis posterior, flexor retinaculum longus, or flexor hallucis longus. It may be any muscle or a tendon that can cause tenosynovitis. And mnemonic for ordering of ligaments and neurovascular bundle aternal will be Tom, Dick, and a very nervous Harry. So Tom, Dick, and a very nervous Harry, right? See, T for Tom, tibial nerve, right? Then we have D for, here we have flexor digitorum longus, flexor hallucis longus, and a very nervous Harry, very V. We have this thing, and nervous, and then hairy. Alright, so mnemonic for ordering of ligament and neurovascular. Neurovascular bundle include vein, artery, and nerve, right? So this is V for vein, artery, nerve, and then we have this this T is actually what? These are the tendons, right? And H, we have to see the H also. What H is actually here? It's vein, artery, nerve, and lymph nodes, right? So what is this H about? I'll see, and I'll get back to you later. For the testing, we'll go for the electromyography that will confirm the diagnosis, and we'll go for the clinical examination that will show the positive tunnel sign at the tarsal tunnel. So if it's a positive tunnel sign at the tarsal tunnel, then this is actually positive finding in the case of tarsal tunnel syndrome. And we ask the patient for this use of a steroid. That's the best initial thing, and we'll go for the steroid injection. We'll go for the tunnel release for progressive nerve damage, but of course with the passage of time, right? But starting with the NSAID steroid injection, and then you will go for this tunnel release. Now hallux valgus bunion, that is deformity causing pain over the great toe at the metatarsophalangeal joint. You are going to see this deformity at the MTP, and pain with walking and blister can occur. Don't confuse with the gout. You're not supposed to confuse it with the gout, which has similar location with different etiology. Location may be the similar one, but always etiologies are different. So we'll go for the clinical testing, we'll go for the X-ray imaging, and orthotics and surgery will be the best suited option, best suited medical treatment for this hallux valgus. That is orthotics and surgery. First we'll go for the orthotics, and then if it's not cured, then we'll go for surgery. Now if you're just going to revise this all miscellaneous orthopedics, then common bursitis, we are not going to actually revise it, just we are going to cover the miscellaneous, like overall a general orthopedics problem like common bursitis. It's usually occurring in posterior knee, and where and why? Because of Baker's cyst or popliteal cyst that can cause this bursitis. And what's the presentation, how the patient is going to present if it's a case of bursitis? Inflammation of the synovium causing an outpouching in posterior popliteal space, asymptomatic bulge that when it ruptures causing pain that can mimic a DVT because of increased warmth and edema. And ultrasound is best diagnostic test to rule out DVT. Risk factors include osteoarthritis, rheumatoid arthritis, meniscal tear, or other trauma, any articular trauma we can see in the case of posterior knee, if the posterior knee is involved, which is because of Baker's cyst or popliteal cyst. And these are the all thing, and we must remember that ultrasound is the best diagnostic test to rule out DVT here in this case. Now we're coming towards medial knee. Medial knee is also known as pes anserine. That's pain with palpation just inferior distal to the medial joint line of the knee. So if there is pain with palpation where just inferior or distal to the medial joint line of the knee, and that is a pain of medial knee. Insertion of three muscles is there: sartorius, gracilis, and semitendinosus, which all have different action and therefore is associated with the overuse. So this is all because of the overuse of sartorius, gracilis, semitendinosus. They can all lead to medial knee. Now superior knee, superior knee we can say in the case of like the suprapatella. Suprapatella is an example here, and this bursa communicate, especially if we can see this superior knee, especially we'll see the location and the pathology. So pathology, location is superior to knee, and this is suprapatella bursa, and this bursa communicates the joint space of the knee and become inflamed and enlarged with osteoarthritis. Right, with the time of osteoarthritis, we can see the involvement of this particular bursa. Then on the inferior knee, there is prepatellar housemaid's knee, that's known as prepatellar housemaid knee. This bursa is superficial to the patella. Of course, it's superficial to the patella, it's prepatellar, and therefore easily exposed to trauma. Repetitive kneeling in professions such as cleaners, the carpenters, the plumbers commonly develop this. So those who are actually these patients, there are many chances that they can injure their, especially just because of the repeated movement, they can damage this bursa, right, which is actually located in inferior knee and known as prepatellar bursa. Now, lateral hip location is there, and the bursa is towards the greater trochanter, and lateral hip pain will be there over greater trochanter where gluteus medius inserts. So, pain while sleeping on sides or with external rotation and resisted abduction. There is association with iliotibial band syndrome, right, that is known as ITBS, iliotibial band syndrome, that we can see. And especially most of the time in case of lateral hip, we'll see the lateral hip pain over greater trochanter. So over greater trochanter will be a pain of lateral hip pain, right? Then olecranon is just it's a student's elbow or craftsman's elbow or miner's elbow. Posterior elbow pain will be there. Most commonly occurs from recurrent gout exacerbation. However, it can be a result from minor trauma from occupation that cause patient to put pressure on their elbows, like student or carpenter or housemaid. So they can all have this sort of bursa and the other complications. Then we have how we are going to diagnose this patient. Clinically, we have to go for the physical examination that reveals swelling and tenderness with palpation over bursa. If there is tenderness and swelling over the bursa, we can say, yeah, this may be a case of this, especially by this bursitis. Then for the diagnostic purpose, we have to aspire the bursa. Aspiration of the bursa. If a septic bursitis is suspected, like erythema is there, warmth condition is there, we'll go for the aspiration of the bursa. For the treatment option, avoidance behavior and conservative therapy will provide, like by asking for the rest, giving NSAIDs, ice especially, and corticosteroid injections, right? And antibiotic we can also prescribe for 7 to 10 days in septic bursitis. If it's a case of septic bursitis, we will give antibiotic for 7 to 10 days. Now we're coming towards atlantoaxial instability. There are a few topics. Yeah, after this we can play the video, right? So this atlantoaxial instability is actually defined as excessive mobility of C1 on C2. It's mobility of C1 on C2, and this can lead to subluxation and spinal cord injury. Overall, 13% are asymptomatic, 1 to 2% cause pain, myelopathy, and upper motor neuron signs, and can cause behavioral issues, right? Only 1 to 2% can cause behavioral issues. Most of the time, atlantoaxial instability is a very common comorbidity of Down syndrome. It's usually present with those patients who are having Down syndrome. Like 10 to 15% chances are there. And rheumatoid arthritis also. So precautions should be used in patient undergoing intubation. If you intubate your patient, you should be very cautious. How you're going to diagnose your patient? With lateral X-ray films, with flexion and extension. So flexion also, extension also, you will go for the lateral X-ray, and that will confirm the diagnosis. You have to treat your patient with surgical fusion. So we have to apply the surgical fusion for this instability. Now we're coming towards pediatric orthopedics, a very important topic for our exam point of view. This is the Osgood-Schlatter disease, that is also known as tibial tuberosity avulsion or traction epiphysitis, right? So this Osgood-Schlatter is interior knee pain, often bilateral around 25 to 50%, but most of the time is interior knee pain of tibial tuberosities in adolescent children, like in between 10 to 11 years in girls, and 13 to 40 years in boys who are athletic and undergoing a growth spurt. It is caused by repetitive stress from the quadricep tendon pulling on the tibial tuberosity during the rapid growth spurt, and sport, whether like jumping or running or kneeling, make it worse, right? These all sport make the condition worst. We'll ask for the patient for the rest improvement because it will be going to release the symptoms. Now, for the diagnostic point of view, if we are going to make a clinical diagnosis, that will be based on the examination, like pain with palpation over tibial tuberosities, and reproduce with resistant knee extension. That is also a case of Osgood. Imaging is not needed, but lateral plain film most commonly shows soft tissue swelling. So in order to rule out swelling, we'll go for the lateral plain film X-ray, right, of this especially. Now, Tissue swelling and variable avulsion fracture also. Imaging is not needed, but lateral pain film most commonly shows soft tissue swelling. If you want to go for the film imaging technique, you will see the tissue swelling which reveal to avulsion fractures. These can be used to rule out more insidious pathology like tumor and osteomyelitis. So how we are going to treat this patient? This treatment is conservative and symptom resolve when bones completely ossify, like up to 18 months of age. Pain management with NSAIDs and patellar strap to distribute force around insertion of patellar tendon are useful. So we can just go for the pain management point, like just by providing NSAIDs or by giving this patellar strap. Then we have this nursemaid's elbow, that is radial head subluxation. This condition occurs in children ages 1 to 5 years because of traction on forearm, commonly when the child is swung by the arms or yanked by the arm. The radial head slips outside the annular ligament and gets stuck, causing pain and limited range of movement. So this is about the nursemaid's elbow. For the diagnostic point of view, diagnosis is a whole soul clinical. The arm is held still in the pronated position. In which position? Pronated position, and is mildly tender. There is no erythema or deformity in this patient. And how we are going to treat these patients? We have to treat with physical maneuvers. The physician should effect hyperpronation and supination with hyperflexion while continuously applying force over the radial head. So by continuously applying force over the radial head, we can do this supination, we can do this hyperpronation intervention. But usually both maneuvers are performed, resulting in reduction in interstitial relief of pain. So definitely, if we go for the option only, then we can say that they are result in reduction and instantaneous relief of pain that result in. Alright, so here the sport medicine is end. Next time we're going to start this ENT, but before finishing this lecture, I want you to see the videos of remaining tests, right?
Finkelstein.
Examination of the rotator cuff, Job's test. The shoulder joint is stabilized primarily through the
Oh, we
surrounding
have seen this. Yeah, Apley
Apley grind test. The Apley grind test is performed to assess the menisci. The patient is lying prone and the knee is flexed at a 90-degree angle. Gently place your leg on the patient's thigh to prevent the thigh from moving, and apply a downward pressure to the knee joint with both hands. Alternately rotate the lower leg internally and externally. Medial pain on external rotation indicates a damage to medial meniscus, while lateral pain on internal rotation suggests a damaged lateral meniscus.
Finkelstein's test can be utilized to identify.
Alright, so now this is the end of this. So tomorrow inshallah we are going to start ENT. Thank you so much.